things that we're going to do is focus on proper nutrition, calcium supplementation, weight-bearing exercise. We're going to prevent fractures, and we're going to provide a lot of education about the use of drugs that we use to prevent osteoporosis and rebuild bone. Basically, hip fractures are decreasing, and one of the reasons is because of some of the lifestyle changes that we've seen in possibly medications. 30% of people that have a hip fracture die within that following year, and many of them experience long-term significant loss of function. Remember, another 30% require long-term care. They can't go back to their own house. They may need assisted living or even nursing home care. Most fractures will occur in women, which is probably a good thing because more men die because of that hip fracture. Yes?
I actually was speaking to a geriatric doctor last year. He said that it's about 50% that die within that first year now.
Really?
Those numbers have gone up.
Well, and if you think about it, it sort of makes sense because we've got a lot more older people, okay? Whereas used to be the average age at death was in the low 70s. Now it's 87.2 or something like that. So as our population gets older, I expect those numbers to continue to go up because older people have a whole lot more comorbid disease processes. Comorbid meaning along with, okay? Because rarely do you have someone in their 80s that doesn't have a little touch of type 2 diabetes, they don't have a little touch of hypertension, they don't have a little touch of COPD because emphysema or asthma or smoking, okay? So I can see that, yeah, 50% is probably a better estimate. Now, one of the things that you'll find is that our nursing diagnosis, these are going to be our priority ones. Risk for falls, risk for injury, altered nutrition. All right, this is less than body requirements. I don't like to write it out. Related to inadequate calcium and vitamin D intake. Knowledge deficit related to drug therapy, and then impaired physical mobility related to pain. These are your priorities. Probably number one is going to be that risk for falls. Now, a couple of things that we do for fall prevention is hazard-free environments. Remember, in your hospital rooms, make sure all the clutter is out of the way. The trash can is not in the way of the route to the bathroom. When I was teaching over at Carolinas College, I used to get these care plans that I knew that they were copied right out of the book because it says remove throw rugs. And I would write back on their care plan, if you show me a throw rug in this hospital, I will give you an A on your next test. Never got a take. Because there are no throw rugs in the hospital, but there are at home. Okay, but what we need to worry about whenever they're walking to the bathroom, think of those scuffs. Okay, that a lot of the little old ladies like, the little slip-on slippers that may not have that rubbery bottom that they slide out from under you, or if they've got the rubbery bottom and they haven't been washed, they catch and you pitch over. Okay? Think about what their fall assessment scores are and do that fall assessment. Whether you use the get up and go test or whether you use something else. Think about what your fall assessment is. Okay? Any of you ever seen the get up and go test used? Okay. Get up and go is one of those things that it's really simple. You sit them in a chair. them to stand up. And if they can stand up without any assistance, then that's a good score. But you saw what I did? When I got up, I used my hands on my knees to push up. If I do that or push up on the chair arms, then that increases my fall risk. Okay? So the more assistance it takes for them to get up out of that chair, the more likely those people are to fall. And some hospitals use that. Others use other fall assessment scales, but whatever the hospital requires, please do that because it will give you an idea. Now, hip protectors. Some people say they work, some people say they don't. All right. Any of your kids play high school football, or if you played high school football, think about those football pants with the hip pads on, okay? That's basically what these are. Some of them are that molded plastic, some of them are just padding, okay, that goes over the hip. However, I will tell you, ladies and gentlemen, getting these things on is like putting a girdle or those body shapers, okay? Don't use them with your incontinent clients because you will never get them off, because it's like peeling a grape to get these things off, because they're not just underwear. They're underwear with a little bit of spandex, a lot of spandex in them. Okay, but what these do is they sit over the hip and protect it. Now, there have been varying studies that show, some show that they work well, some show that they're a nuisance, and they are not effective. But you will still see them out there used. However, a lot of women refuse to wear them if they're not made to, because what does it do? It pads your hips, and so it makes you look wider. So, but hip protectors you may see used. Dietary calciums, good sources: milk or milk products, green leafy vegetables, seafood, particularly bony fish like sardines or herring, almonds and hazelnuts. And it doesn't take that many. 15 almonds is a good source of calcium. It also is a very good source of a nutritious snack, okay, that will fill people up. Now, poor sources: eggs, beef, poultry, pork, or fruits. These basically contain no calcium. Milk and milk products. Remember, you may have the problems with patients that have lactose intolerance, and they will be gassy. I love that Lactaid commercial, okay, where the little cow is doing the little balloon. Sounds like gas escaping. But I have not looked to tell you. Those of you that do soy milk or almond milk, look and see what kind of calcium it does have in it. Probably, I would think almond milk would be a good source because of the almonds here.
I think almond milk has more calcium.
Yeah. What I would also tell you is that I lost my thought. You need to know per age what the calcium intake needs to be. Okay? Basically, one of the things that you're going to see is that it's recommended that we take in for postmenopausal women about 1,200 milligrams of the elemental calcium. Okay? 1,200. Now, what you often see is that the requirements are 1,000 milligrams up to the age of menopause, with the exception of women that are pregnant. Okay, and then they go up to 1,200 milligrams during pregnancy. Basically, you don't want to take in excess of 1,200 to 1,500 because of the risk of kidney stones. Again, lifestyle. That exercise, we want to strengthen our abdominal and back muscles. It reduces the risk of vertebral fracture. Walking 30 minutes a day, 3 to 5 times a week is very important. Smoking cessation is extremely important. Because 3 times you kill a mule. That's what my granddad always said. So somewhere out there's a mule that just fell over. All right. Smoking cessation is very important. Now let's talk about calcium. Do you want to take calcium carbonate or do you want to take calcium citrate?
Calcium carbonate.
Makes no difference. The thing that you as the nurse need to remember is that calcium carbonate has to be taken with food. All right, how do I remember that? There are carbs in the food you eat. So carbonate has to be taken with food. Citrate, it doesn't matter when you take it. You take it with food, without food. Bedtime, whatever. However, in order for this calcium to really work, we need to make sure that they have adequate vitamin D as well. Okay? Basically, this is just some recommendations. I think I misspoke. 1,000 milligrams is for 19 to 50-year-olds. 51 and above, this is presuming postmenopausal, the 1,200 milligrams. But look at your teenagers here, 1,300 milligrams. It's the recommendation. We want to build that bone as strong as we can. Go by this one. Okay?
This chart.
Vitamin D supplements. And this is one of the biggies that has occurred in the past, I would say 10 years. Because if you look at vitamin D deficiency, it contributes to a lot of problems, okay? And I will tell you that vitamin D deficiency correlates with death from all causes. People with low vitamin D levels are more likely to die from their disease than people with normal vitamin D. Why? I don't know. But that's what the research says. So what's the big thing right now is that physicians are checking everyone's vitamin D. And if you're low, you get recommendations to increase your vitamin D intake, or you're put on medication. Now, how do we normally get vitamin D other than seafood, mushrooms, or egg yolks? The sun. All right, but I'm going to tell you, if you put on sunscreen that's higher than an 8, you get no vitamin D from the sun. You have to have at least 15 minutes of unprotected sun exposure to have vitamin D made in your skin. Now, what do all the dermatologists say about that? Skin cancer! So, typically
Eat mushrooms.
you eat mushrooms, and egg yolks. They have omelets. And I don't think the McDonald's steak, egg, and cheese burrito, breakfast burrito works. But what I would tell you is that any of you worked in long-term care where you have orders to take the residents outside for 15 minutes?
Nope.
Nope.
Not anymore.
Wonder Guard.
They're gonna escape.
Yeah. Typically what they would do is they would roll everyone out on the back porch for 15 minutes and then roll them back in, and that was to increase their vitamin D. Well, how do most little ladies go out in the sun nowadays, especially your elderly women? They've got a blanket on their legs, they've got a sweater on their arms, and they've got a hat on their head. So the only thing that was exposed to the sun was probably the tips of their fingers. Okay? That's not enough. So typically we don't see that anymore. If people are vitamin D deficient, they put them either on vitamin D3, which is cholecalciferol, or vitamin D2, which is ergocalciferol. The sun basically shining on your skin makes vitamin D3. Our body uses that much better. But often what you will see is D2 undergoes a chemical change in the body and becomes D3. Now, why would I even think about prescribing D2 instead of D3?
So D3.
You wanna make them work for it.
Yeah, make them work for it. Well, no, but it is a dietary concern. D3, cholecalciferol, is made from animal sources. D2, ergocalciferol, is made from vegetable sources. So typically your vegetarians or vegans will be taking the D2 instead of the cholecalciferol. And then some physicians just like D2 better. I don't know. But typically, if you have someone that's vegetarian or vegan, they would be on the ergocalciferol. Recommended that you get 800 to 1,000 international units per day. Okay? Typically, if someone's deficient, they will put them on a little bit higher dose, and then once their levels come up, they will do the 800 to 1,000 international units. All right, let's take our break before we do drug therapy. Evac has osteoporosis. It's the best of all possible world. However, it is not used with history of people with VTE, venous thromboembolism, okay, or DVT. So, because any of your estrogen agonist or antagonist basically increase your clotting risk. So people that have that medication should be taught signs and symptoms of DVT so that it can be early recognized and that it can be treated appropriately. If they develop a DVT on this medication, they're taken off of it. Now, parathyroid hormone or teriparatide or Forteo, okay, is another medication that's approved for treatment of osteoporosis in men and women. Parathyroid hormone or this medication stimulates new bone growth, okay? You need to teach these people signs of hypercalcemia. Because remember, parathyroid controls calcium level. And if you stimulate or give them more of this hormone, they can develop a high calcium. Those symptoms are the fatigue, the anorexia, nausea, vomiting, constipation, and polyuria. Polyuria means peeing a lot. Typically, you will see this with people that are high risk for fracture. Okay? It's also used for people that are taking steroids. Now, it is administered daily by sub-Q injection. It comes in one of those little self-contained pens. I know you've seen the insulin pens that you just dial and inject, okay, after you put a new needle on. Basically, this is very similar to that. You dial up your dose and inject. However, it is used for a maximum of 2 years because it can stimulate bone growth to the point where they can develop osteosarcoma, which is a malignant bone tumor. Now your bisphosphonates, the bises, are the 8s. Okay? Adrenal dronate is Fosamax. Ivandronate is Beniva. These two are taken by mouth, and typically what you will see with them is they're only effective if they're given along with the calcium and vitamin D. Now, there are a couple of things that you have to remember about these. That's very, very important for patient teaching. They have to be taken anywhere from 30 to 60 minutes. Fosamax is 30 minutes. Beniva is 60 minutes before anything else. So you can't have breakfast and take your pill. You have to take your pill and then wait the appropriate time and then eat. Okay? And that includes drinking as well. These medications should only be given with water and a full 8 ounces of water. Basically, what you're trying to do is to make sure that that pill gets to where it's going. You know, most of your medications say to take with 4 to 8 ounces of water or fluid. And what do? You take a sip, throw your head back, and that's it. This, you must take the full 8 ounces. One of the side effects of this medication, if it stays in the throat, is esophageal erosion. Okay? So, if I have a patient on this medication and they're now starting to complain of, you know, I've got bad heartburn, they need to see a physician to make sure that they have not got esophageal erosion. Okay, that full 8 ounces of water is to flush that pill down to the stomach. Okay? The other thing that they need to be taught is they need to be in an upright position. This is not one that you can take, get up, and, well, I'm going to lay down for a few more minutes while my pill is working. It has to be sitting up in a 90-degree angle. So you get up, you watch Good Morning America, you take your pill, and you watch the rest of Good Morning America, and then you go eat your breakfast. Okay? Basically, one of the things you're going to see is that long-term contraindication for these medications is going to be poor renal function, hypocalcemia, or GERD. Because if they have pre-existing GERD, we don't know if that's their pre-existing problem or they've started to develop that esophageal erosion. Okay? Now, the Actonil or the Risdronate, okay? This is a medication that is given I want to say, let's see, maybe once a month or so. The others may be once a week or once a month. This one I think is given by IV. Reclass zoledronic acid, I know, is a medication that's given once a year by IV. And typically what you're going to see is that it's given over at least 15 minutes. It's in high-risk patients that may have experienced a low trauma fracture. Typically we pre-treat these people with Tylenol to reduce the risk of an acute phase reaction, the arthralgia, headache, myalgia, and fever. Okay? In other words, joint pain, muscle pain, headache, and fever.
I feel like you have the flu.
You feel like you had the flu that jumped on you with 42 feet. And it's like sudden, you know, how you feel that prodromal symptoms, you know, I don't feel well when you're developing the flu. This is flu full on. And that Tylenol will prevent it.
I didn't tell my mom that. She ended up having that. She was sick the entire day.
Yeah.